Welcome everyone, this is Brad Calobrace. This is another roundtable for the Aesthetic Society. I'm really happy to be joined by Pat McGuire, Louis Strock, and also virtually with Steve Sigalove from Scottsdale, Arizona. Really a great panel, and what's unique about this panel is they've all been surgeons who used a lot of texture in their career, and of course recently that's changed, and they've gone to either less texture or more texture. So we want to learn from them how they went about that transition and where they are today. So I think I'm going to start with Pat and just ask you, talk to us about your experience with texture, when you used it, when you stopped using it, and what are you using now?
Yeah, I'm kind of unusual as an American plastic surgeon that I love textured implants. I used shaped textured implants for many years, and I think in a discussion we had before, at the time there really wasn't anything better starting the early 2000s. I stopped using texture in 2016 after two of my partners had ALCL cases, and it wasn't always an easy transition. We do have better implants now than we had back in the early 2000s, and to go from shape to smooth, especially for reconstruction and for some constricted breast deformity, and for texture in a constricted breast deformity on some of my transgender patients, I found there was a big advantage to it. Patients with a pectus excavatum or pectus carinatum having that position stability that I think you got, especially with macro textured implants, I loved them, and the results looked good, and they looked good long term. When I changed to using smooth, which I did relatively abruptly, I also found I had problems that I didn't have. I never had to worry about managing my inframammary fold because those implants stayed where you put them. And I had some inferior and lateral malpositions early on, so now I'm much more careful with my fold management. And you also have to, it's a different feel to the implant. If you're doing an exchange from textured to smooth, the patients have to be prepared for a difference in feel, a difference in position. But now we do have more technologies with mesh and fat that there are other options to use. And I think the implants are much better. The more cohesive gels work very well. You can get kind of the same advantages without the potential risks.
Yeah. Louis, where are you? Are you 100% smooth now?
Yes. So I stopped using texture in 2017. I agree with most of what Pat just said. I think for me, I used micro-textured shaped implants quite a bit. I had morphed toward using shaped implants that were taller than they were wide, which to me helped counter some of the tendency to rotate on occasion. I switched, and I think that it really just kind of came down to a personal decision about risks with ALCL in particular, BIA-ALCL. Now that being said, to me the real value of the shaped implants, and even though they're micro-textured, I did find that they help tremendously with positional stability. Not perfectly, but fairly consistently, particularly in patients with an angled rib cage, revision cases, and I did a lot of augmentation mastopexy as well. So to me, the enemy of many of our breast implant operations is unwanted device movement. So if we're going to smooth, we're taking that on. So in using the newer smooth implants with different types of gel fills and different gel thicknesses, I'm trying to counteract that same issue. So I've done that through using resorbable biologic meshes as an off-label use for added tissue support in revision cases, some primary augmentation mastopexies in patients with massive weight loss, and in patients with angled rib cages. Another thing I have sort of been moving toward, and maybe Steve, thanks to your influence to some degree, but I have been doing a little more subfascial work, particularly in patients with angled rib cages. Because I'm just trying to do something to keep the muscle from pushing the implant down and out along that angle over time.
Yeah, I think, Neil Handel's talked about it and others for a long time, that the muscle has a deforming, effect on the breast and the implant position, there's no doubt. And if you want to keep an implant in position, especially in a sloping chest wall, sometimes just not having the muscle involved can be extremely helpful. And I totally agree that a frictional coefficient sometimes is enough to stabilize an implant without the need to have true adherence that we see with macro textures. So Steve, you've been very involved in reconstruction for a long time, and I know now you have a growing and large aesthetic practice too. Tell us a little bit about both in recon and aesthetics where you sit on this.
So for many years, for my breast reconstructions, particularly in pre-pectoral, I only used anatomical macro textured breast implants. And in prepectoral breast reconstruction, I really saw a significant improvement in the overall aesthetics, because in prepectoral reconstruction, you truly are shaping the breast with your implant without any distracting forces of the pec muscle. So the implant is completely shaping the reconstructed breast. And so a beautiful tapered implant is going to show up as a beautiful tapered breast. When that all changed, like Lewis in like 2017, I switched to all smooth. And I think that one of the things that the textured experience gave us is an improved technical ability to dissect the pocket. And whether it's reconstruction or aesthetics, I think because we learned how to be meticulous with our dissection using texture devices, we kind of carried that over to the way we do surgery with smooth implants. And because of it, we're no longer over dissecting, making these massive pockets. We're making beautiful, tight, perfectly fit pockets for the device. Sometimes we're supporting those pockets with bioresorbable mesh, sometimes not. Sometimes we're doing fat grafting. So I think a lot of the things that we learned from breast reconstruction, we have kind of have brought into our aesthetic world, and at least I have. And it's really, I think, been a game changer for my aesthetic practice, moving to a subfascial augmentation placement. And, you know, a significant number of my cases, probably 85%, I do subfascially. I support all of them with bioresorbable mesh. And thus far, things have been really nice. And I think not having the pec involved is very, very, it's very interesting. And there are a lot of patients who don't want animation, a lot of patients that want to be able to do full chest workouts and Pilates and yoga, et cetera. And so I think there's something to be said for not cutting the pec muscle on every case.
So in Recon, you were wrapping with ADMs in your prepectoral reconstructions, and I'm sure you do that to some degree. Then you were trying P4HB as a possibility. So now compare that. Now smooth devices that you're using round prepectoral, what are you wrapping them with?
Yeah, so I've converted my entire practice from ADM to P4HB. And what we see is significantly less rippling. We're seeing a completely stable and rigid pocket with less malposition. There's less fat grafting because the pocket remains tight. So in ADM reconstruction, I was fat grafting about 86% of my prepectoral recons. Now it's about 24%. So my fat grafting has cut down because I'm rippling and wrinkling much less. The other thing that we learned about a P4HB compared to ADM is we're not seeing the same AP malpositioning that would occur invariably with ADM, because you have a stretch of your pocket because it's dermis. Now with P4HB, it's a rigid pocket. So you can now use an extra projection, highly cohesive gel implant and not worry that it's going to turn on top of itself, because your pocket is now rigid and stable. Less drainage, our drains come out faster. So it's really been a game changer switching over to the P4HB product.
When you see less wrinkling, I wonder, is it because you've switched from textured to more cohesive smooth devices? Or were you seeing the same thing when you used textured wrapped with P4HB? So the other issue, and I believe that, you know, upper pole rippling has a lot to do with lower pole and anterior pole failure. So with your meshes controlling your lower pole, I would think that would be contributing to your lower wrinkle rates as well too. So how much do you think it's because you have a more cohesive smooth implant instead of a shaped textured implant that you're seeing less wrinkling?
I think it's the pocket itself. Because in my aesthetic patients, I'm using soft gels in many of the primary augs, and I'm not seeing any rippling. So I think it's the pocket itself. I think it's very important to control the lower pole. If you can control the lower pole, you can in turn control the amount of rippling in the upper pole and the traction rippling.
I agree. So that being said, so Lou, when you're deciding on which cohesiveness of a smooth device to use in a secondary case, and you do a lot of secondary cases, talk to me about what you think about a modest cohesive implant versus a highly cohesive implant, and how those act in a pocket, and especially in a pocket that has a sloping chest wall. How do you decide on an implant for those?
That's a great question. So I'm 3 years into this journey using no texture. Here are my observations. On the one hand, you have Allergan, who has a spectrum of gel thicknesses in terms of the implants that I use. Soft Touch is the implant I like, that product line, because to me it gets it right. It comes from my long background of using shaped gels of different consistencies. I really like that implant a lot, whichever profile. Mentor, on the other hand, has a cohesive one gel with a higher fill ratio than their older implants. So to me, the more highly filled, if it's a full profile, an SSF, as opposed to SSM, that patient I will always use added support, because to me that's a higher risk of a malposition, particularly if every angled rib cage is involved. It also will give a more distinctly round upper pole in my hands if you support the base of that pocket, like we've all been talking about, Steve just mentioned a minute ago. I think that the more cohesive gel just gives a rounder look. For someone who wants a slightly softer contour, might use the Moderate Plus Extra product line. I always talk about mesh, whether I use it or not, on secondary cases. I've gotten to where I use it more often than not. I think there are differences in the look created with those two product lines by comparison. But I've been happy. I've been happy with the capabilities and the differences between the different manufacturers and different projections.
So Pat, do you use any either ADMs or meshes in either primary and or secondary breast cases? And if so, which ones?
Primary, I do not. My patients don't have, a lot of breast augmentation patients are price sensitive. You add in another few $1,000s worth of mesh. I don't oversize implants. I do some dual plane and some subfascial. All my transgender patients, I do subfascial. I do believe there's a fascial plane, especially on my trans women, above the areola. It seems like, or at the level of the nipple and the areola, you can elevate. And I do think it helps stabilize the pocket, especially superior. It's like the roof on my dissection. So on those patients, but on my dual plane, women who worried about mammograms, or they're you want to have children and they don't want an implant sitting in the middle of their breast. And I see a lot of younger women, but I don't do big implants. I tend not to get patients who want that. So primary augmentation I almost never do. Secondary depends on the problem. Yeah. If it's a malposition, if it's a first time malposition, it just looks like it was a technical error from the original surgery. I'm not upsizing an implant. A lot of times I'll do a capsulorrhaphy. I did a case in Atlanta this year where I downsized implants, and I just used a barb suture with a few permanent sutures, reinforce it, and I talked to that patient a couple weeks ago. She's doing well. Now 4 months post-op. It seems like years ago that we were in Atlanta, but on a secondary, it depends on the indication. For malpositions, if it's a first time, which is a previous oversight, if I'm downsizing the implants, I don't. If I'm staying the same or upsizing, you always have to make sure plan B is different than plan A. Yeah. So I have to see what was done initially and see what I can do to prevent the patient's having a revision for a reason. I want to do what's will lower that patient's risk of needing another operation.
Yeah.
Brad, just to clarify, when I mentioned using added soft tissue support, so in a primary situation, I'm using it for augmentation mastopexy in thin tissue patients or patients with an angled rib cage, or massive weight loss patients. Otherwise, it's revision, but not a straight augmentation primary.
Yeah, I do think that the weight loss patient's a unique patient. It's always such a challenge. If you want sort of coverage and support, so you have a tendency to want to go under the muscle, but then you get a waterfall deformity from that unstable soft tissue overriding it. If you go subglandular or subfascial without support, you invariably lead to a very stretched deformity with loss of upper pole volume and stuff. So I think it's unique. Steve's situation of using subfascial. Lou, do you do subfascial? Do you believe there's a subfascial plane?
Oh, I know there's a subfascial plane, but that's because I do a lot of axillary surgery. Yeah. So right. That's particularly enthusiastically described by axillary surgeons because that's where it's thickest when you're seeing the lateral pec through a transaxillary approach. So as Pat said, I too have found that it really is very difficult to see it once you're getting around the areola nipple area coming inferiorly. It gets hard to see that layer. So a primary inframammary surgeon, I could see the lack of enthusiasm or belief in the existence of that plane because it's harder to see it until you get a little higher.
Yeah, I agree. And so Steve, Clearly, I loved when you were talking about the tight pocket, because I do believe when you're above the muscle that the subfascial plane provides much more of that stability versus the subglandular pocket, especially in a weight loss patient.
Absolutely. And I think it hones in on the fact that we are performing meticulous, sharp dissection. This is no longer the old-fashioned subglandular, put your finger in and spread that avascular plane. This is a true sharp dissection, and we're being meticulous, a hand-in-glove fit. We're doing it by biodimensional analysis. We're choosing implants that are appropriate for the patient's base width, and we're really turning it into a very safe and natural operation. And because of the extra added support in the lower pole, I think we're adding longevity to these potentially problematic cases.
Yeah, I do think that medially too, that the fascia is a protective layer because it comes across medially, and you do that dissection. I think it's easy, even in secondaries, inadvertently, or in primaries, to inadvertently go too far. And once you put the implant in, it starts to create that sort of either true symastia or at least some sort of an aesthetic symastia that looks like you've invaded the midline. And so the fascia is very protective in that way. You know, Pat, you mentioned something I think I hold dear to my heart in describing, and it is controlling the fold, right? I believe both in primary and secondaries. So you mentioned this, especially it relates to using smooth implants now, that it wasn't ever important before, it's important now. Tell the viewers why that is.
Yeah, well, if you go back to reconstruction, like Steve said, you know, the best reconstructions are the ones that have good inframammary folds. If the cancer surgeon left your inframammary fold, those are always home run breast reconstructions. And breast augmentation is the same thing. A well-controlled inframammary fold is the difference between a good result and a bad result. And that nice, crisp inframammary fold is really important. And so I now always fix a fold, which I never did. When I used textured implants, you could put the implant in, they'd stay there, they didn't move at all. Now I really am very careful about it, and I take Scarpa's fascia and do interrupted sutures down to the chest wall. And I want that incision, to me, a successful result. When I see that patient back in a year, that scar should still be exactly in the fold where I placed it with my sutures. And I also, going on a smooth implant, I learned from Per Haden, is I keep these patients in a bra. I used to tell patients it didn't make any difference whether they wore a bra, didn't wear a bra. I now keep smooth implants, and when I've used nano-textured implants, in a bra for 6 months. And I do think you want a favorable pocket to form, or favorable capsule to form in the shape you want it to form in. So I keep my patients in a bra for 6 months. I used to let them do whatever they wanted 4 weeks later. Now I'm very careful about, especially if it's on a dual plane, to make sure they're not doing anything excessive stretch with their muscles on their chest either for 6 months.
So Lou, do you control your fold?
That's a subject I've always been very interested in. So I do majority of my breast augmentations transaxillary.
Yeah.
And so we can't sew it down.
Yeah.
And it has seemed to me that an inframammary breast augmentation, it's actually easier to lose control of the fold, inframammary. And the reason is most of us are putting in a retractor to see what we're doing. And I think it's very easy to get some unintended stretch of the breast tissue or surrounding structures around the fold simply in doing the operation. Therefore, the reinforcement sutures like Pat's mentioned and Bill's described over the years are really important. Now, so how do I deal with that transaxillary? Well, what I do is a technique that Pat Maxwell described in a reconstruction article from about 1990 with an author named Falcone doing 1-inch foam tape along the IMF, which I leave on for a week with my breast augmentations. I do, we custom fit a custom size, that is, underwire bra that I like them to wear. For 2 months, we discussed that in great detail. My office staff implements that. So I too am very protective of that, because to me that's going to determine the long-term outcome, and we need to stabilize it aggressively postoperatively.
Yeah.
Are you doing subfascial mainly?
No, I do mainly partial subpectoral, but subfascial is on the increase in my practice. Depends on the patient.
So Steve, do you lock down your fold?
So every subfascial aug I do is locked down with P4HB mesh. So my fold is literally defined by my inset on the chest wall at the fold. So in my subfascials, but in my dual planes, I typically am not using any supportive devices. And so just like Patty, I'm very meticulous about closing scarpas down to chest wall. And then I kind of do like a somewhat of a permutation of the Lucky 8 stitch. I call it the Lucky 4 because it's kind of half as strong as Charles' stitch. But I think it's critical to do that. But in the subfascial, I don't have to because I'm doing it using the P4HB.
Yeah, referring to Charles Rehnquist, who had his Lucky 8 stitch for locking down the fold. And why Charles did that a lot was because he routinely lowered the fold. And so, like I've always said, in a fold that's inherently unstable, because there are folds that are not that well developed, and or when I lower a fold, I think it's imperative to lock down a fold no matter what you do. Like Patty, though, you know, back in the textured days, if I had a really great fold, probably it didn't really matter as much whether I locked the fold. I do it for routine. What I tell my fellows is there's never a time when I want the implant to descend lower than my incision, right? There's never a time when that's appropriate. So why surgeons depend upon that is because I have surgeons who say, I never lower the fold, right? And I always go, that's impossible to never lower the fold. But you know, we've all heard that surgeons don't like to lower the fold because of the problems. So we're gonna do one more discussion as it relates, because it will help the surgeons listening to finish this up. And it's the treatment of the tuberous breast. Because now everybody cites textured implants or shaped textured implants as distinctly advantageous in the treatment of that patient for fold control, expansion of the lower pole, all those issues. So I want to ask each of you, how do you approach your tuberous breast patient now? So I'm going to start with Louis this time.
It depends on where they are on that spectrum.
It depends. I like that one.
How's that for a non-answer?
Yeah.
No. Okay, so in the very tight tissue, extremely narrow tuberous breast patient without a lot of ptosis, that patient, that's the one patient that I might I might actually lower the fold in an augmentation mastopexy. It's the one time I do it. More cohesive gel is the approach for me on that. If it's severe radial scoring, but really more cohesive gel.
Do you do that through an axillary approach?
No.
Okay.
No. So, if it's a straight augmentation and they don't need a mastopexy, yes.
Yeah.
Yeah,
Okay.
I do it axillary.
Okay.
There's nothing real remarkable about it. You can do radial cuts, scoring cuts and all that through the axillary endoscopic approach. Now, if a mastopexy is involved, again, I still want more cohesive gel. I want a fairly projecting implant. So I used to like saline implants for that because they're a little stiffer.
For
So I'm
sure.
trying to create a stiffer dynamic to shape the tissue to round it off, because it usually looks very pointy as they look down at themselves, et cetera. So we're trying to round it off, so a stiffer implant is really the concept.
Yeah, exactly. Steve, how do you approach tuberous breast?
I do everything through an inframammary incision. I'm dropping their folds, obviously, and it's all about lower pole expansion. This entire case is really about lower pole expansion. And in the old days, yes, an anatomical implant was amazing for that. I'm using a highly cohesive gel product, and I'm doing it all subfascially. And I think it's, for my cases, when I switched to all subfascial, especially in my tuberous breast, they just expanded so much better. By not worrying about that pec, I just feel like I get better overall expansion, particularly in the lower pole. And I'm supporting every single one of those with P4HB. And I've been very happy with the results thus far.
Does that inhibit your expansion of the lower pole by putting that mesh in there? Because it seems to me, so you getting your full expansion on the operating room table?
Yeah, I'm doing it. I'm getting it on the operating room table, and I'm dropping the fold all at the same time. So if anything, the mesh is stabilizing that fold that I've now dropped. And so I'm not worried about malposition as much as if I just did it without the support.
Pat, where are you at?
Yeah, I think the anatomic, highly cohesive implants were great for the constricted breast. I never score the lower pole. Those patients already have thin tissues in the lower pole. You expand that out, you might thin them out even more. So I used to always tell those patients when I use an anatomic implant that it's going to look odd, it's going to be very flat, and it's going to take a year. but that implant would hold its position and would over time expand the lower pole out. It's like saline implants, kind of that water hammer effect over time. I think you do have to be careful with a dual plane. It's very easy to get a double bubble on those patients. Careful about these are patients where you have to lower the fold, but I don't pick an implant where I'm gonna have to lower it a lot. I don't like a long nipple to fold distance anyway, but if you have a patient with a 4 centimeter nipple to fold distance, you're gonna have to lower that fold quite a bit. So now I use the more cohesive gel, either the highly cohesive or a soft touch, and to still tell them the same thing. It's gonna take time for that to expand. I think I do a lot of transgender patients, and they're essentially a constricted breast. I do them subfascial, and they do expand with time. I use the soft touch on those, less wrinkling and rippling. It does expand over time. You really have to carefully figure out exactly where you want your fold to be and fix it down well, because that's a patient that's just like asking for an inferior and a lateral malposition. So more cohesive gel. Fat grafting to the lower pole I think is a good idea. I think a smaller implant with fat grafting is probably ideal, but a lot of these are young, skinny girls that don't have a lot of donor sites for that. But that's probably in the absence of an anatomic, highly cohesive implant. I think a smaller implant with fat grafting is probably now the new ideal for those patients if they have enough donor site.
Yeah, and I think we've learned something from Brava bras and pre-expansion, and the fact is that I think in the toughest cases, sometimes instead of using a tissue expander or something else, you can do subcision fat grafting and really radial scoring and releases, and band releases in the lower pole, and expand out the lower pole, and then go ahead and proceed with the surgery, and then add some more fat if you need to, as just another option. I agree with you, Steve. I used to do everything through the periareolar incision. I was taught that way, and then you could lower the fold to wherever and do radial scoring, but of course, invariably, the fold did not land where you wanted to. Then you had no way of controlling it. Usually you found out that they were bottomed out, if anything, or at least a double bubble in those situations, and I definitely transitioned. And I will sometimes, the only last thing we haven't said is, I'll use a transposition flap. So instead of just radial scoring, if you get a lot of subareolar tissue, you can actually create a flap and rotate it down into the deficient area and add that breast tissue as just another way, another piece of the armamentarium to get a great result for that. I just wanted to finish talking with tuberous breast because I think in some ways it's a very challenging case. Now we're using a smooth implant. We were used to all using textured. So maybe it represents using everything we have, including meshes and controlling folds and the use of fat grafting to try to get a result that's comparable or maybe even better than textured implants. So thank you, everybody. I hope you enjoyed this conversation. I really do, from all the experts here, all these textured users who have transitioned and getting great results with smooth implants. I know for all of you, you can do the same. So thank you for the roundtable for the Aesthetic Society.